Good morning, everybody. The reason we have chosen this case is so that we may be able to help our budding new phaco surgeons and help them manage their cases better, choose cases better, how to start initially. Uh, this is a case of a 67-year-old male who came in for a routine cataract surgery, and he had a hard nucleus. Preoperatively, the dilatation of pupil was adequate, but this is what happened during the surgery. As we started the phaco, the pupil started to come down slowly. In spite of the gradually decreasing pupillary size, the surgeon somehow completed the phaco and went ahead with the next procedures. At this stage, I would like to ask Dr. Neeta, what tips would you give to our young surgeons in management of the hard nucleus?
I think we are looking at a combination of hard nucleus and small pupil. Is that right?
Yes.
So one thing is that we may manage a little softer cataract in a smaller pupil, but which is very tough in a hard pupil. So if there is a propensity prior to surgery to indicate that this may happen, like a rigid pupil on examination or a patient on Uremax, we always put cyclogel atropine prior to surgery, which makes it more rigid and less chances of it going down at the time of surgery. Also on table, we use phenocane instead of Oculan if there is no block used. And I have burned my fingers once in getting a PC red at the end of IEA in a very small pupil. So I don't hesitate in using a Malugan ring even in between if it is really required rather than struggling through a very small pupil.
Okay. Dr. Meeno, in this case, we managed to complete the phaco through the small pupil. But would you advise using any dilatation devices after completing the phaco?
Preferably, as madam mentioned. So if we come to know in the beginning, like before surgery, if we know that this is a non-dilating pupil, it's rigid. So whatever precautions need to be taken, we should take it prior to the surgery, whatever can be done. Intracameral, as madam mentioned again, the phenocane, as well as we have the topical solutions which are available for intracameral use. That, as well as using a high density viscoelastic, that also helps in dilatation, so that we push the iris lens diaphragm behind and help in dilatation a little bit, as well as use of the Malugan ring or any other rings as required, or even iris hooks for that matter. Previously we were using iris hooks, but we saw the sphincter tears and a lot of other complications. But the BX rings, the other rings, they work quite effectively and help in maintaining a circular pupil. So better we could use such devices too.
Thank you, Dr. Meeno. I will proceed with the video. So this is what happened eventually. We proceeded with the cortical aspiration. And then there you have it. However, unfortunately, this we recognized only later that what had happened. During the surgery, did not notice the PCR at that stage, and we went ahead and put in the lens. I would like to pause the video again at this point. And Dr. Ramamurthy, my next question would be to you. How in such cases do you identify, I mean, in this case, we did not even recognize the PCR at the moment, and we continued as if nothing had happened. But any certain signs that younger surgeons could look for wherein we could know that, okay, there is something wrong?
I think one distinction I would like to make initially is that a small pupil and a small rexus phacoemulsification. Now, if I have a 4 millimeter pupil, if I'm able to run the rexus beyond the margins of the pupil and get about a 4.5 or so, I would not, especially if it's a softer cataract than what you're showing, I would go ahead and do even a conventional phacoemulsification. Otherwise, as was mentioned, always use some pupil expansion device, especially when there's combination of a hard cataract. As far as recognition of PCR is concerned, one thing is there could be a sudden deepening of the anterior chamber. There will be loss of followability, where no longer you find that the nucleus is coming as it was coming earlier during the stages of phacoemulsification. there could be distortion of the pupillary margin because there are vitreous strands coming in. So whenever in doubt, it's always a good idea to put in a little bit of diluted triamcinolone acetate to identify this and then proceed.
Thanks, Dr. Ramamurthy. As we proceeded with the case, the cortex aspiration went on uneventfully. The IOL was put. The surgeon had a doubt, and after IOL insertion, did check once by inserting putting diluted triamcinolone in the anterior chamber and checking for any vitreous loss. And throughout all the procedures, the IOL was extremely stable. So at first day post-op, the patient had a vision of 20/40 and was doing fine. However, on day 9 post-op is when we had a twist. And this was the picture at day 9. And that's when we realized, okay, there has been a large PC tear and the IOL was hanging. We went ahead and did an IOL exchange and replaced the IOL with an iris claw lens. And post that, now the patient is doing fine. And at 1 month post-op, the iris claw is stable and the patient has a best-corrected visual acuity of 20/30.
Was there just a PCR? You lost the rexes also.
Yes. I think the rexes came off when we were removing the IOL, because during the surgery we realized that one haptic was behind the bag.
Before you did this exchange, do you feel that you had an intact rexus?
No. The one haptic was in the vitreous and the other one was on the rexus, but we couldn't see the inferior half.
Okay. My only contention is that, I would have put in a iris hooks, and just in case, because I feel you just had a PCR, and if you had still had an intact rexus,
we could have,
because its haptics are also quite thin, it's not a single piece lens. Could have just brought the same lens anteriorly and placed it on the rexus margin and even created an optic capture.
During the exchange, we couldn't see the complete rexus at all.
Okay.
Any questions from the audience regarding the case?